Hello, it's May the 12th, 2022. This is episode 91 of THCB Gang. I'm Matthew Holt, your host, Balti Boy on the Twitters, founder and publisher of the healthcare blog, THCB, and have a star-studded lineup today, mostly with sort of digital health superstars on it. And we'll probably be talking a fair amount about what's going on in the world of digital health, given that the rest of the stock market has now joined the digital health sector in collapsing, apparently. And the world that we've seen for the last few years may be changing, maybe not. We will find out. Anyway, who do I have on today? I have my co-host at Health Tech Deals and the host of WTF Health, Jessica DaMassa. Raj Aggarwal, innovation consultant working with Panda, Redesign, and a bunch of others. So tell us about what he's up to. Deven McGraw, regulatory expert and head of data stewardship at Invitae, which acquired Citizen last year. And our guest today is Jen Goldsack, another Brit, making 3 out of 5. So Jess and Deven will have to do well to keep the American part going here. Jen is the CEO of the Digital Medicine Society. All right. Well, hi all. Looking forward to the conversation. And let's just kick off. It's been a wild few weeks on the stock market. It's been a wild few weeks, in fact, in digital health funding again. And nonetheless, things seem to be changing in the atmosphere around digital health. So I'm just wondering what, and by the way, there's been other stuff happening outside the digital health world, in the world of health and healthcare, as we all know. So let's just start with going around and seeing what we've all been paying attention to. And I'll start with you, Deven.
I'm fielding a lot of questions about what happens to privacy if Roe v. Wade goes away, or should we say when Roe v. Wade decision gets overturned. So that's been interesting because it's, lots of questions from, is the basis for HIPAA, in Roe v. Wade's constitutional right to privacy? It's not. It's came out of a statute, so HIPAA is not going anywhere. But given the aggressiveness of some of the state laws, that some that are already on the books, some that go into effect immediately if Roe v. Wade is overturned, and some that are being considered that would increase reporting requirements on medical facilities and doctors regarding certain aspects of women's reproductive health. What about these apps that women use around, where they're tracking periods in an effort to either become pregnant or not become pregnant? To what extent do we have protections around data that might now end up being used to really hurt people, put them in jail in some scenarios, or spy on them, track them, et cetera? So yeah, it's all disconcerting, but this piece of it is getting an increased amount of play in the trade press in particular.
Yeah, I think we should definitely come back to that. It's obviously a hot topic and impacts on a lot of these services. Raj, what have you been up to? You've been changing your roles again, I hear.
Yes, absolutely. I can't keep the job down. So last time I was on here, and we met at the Panda Health cocktail party at Vi, if you remember it.
Yeah, of course you do.
I vaguely remember that. I remember the first part of that. The latter part of it's a bit fuzzy.
Yeah, I was going to say your mistake was having an open bar. Otherwise, he'd remember.
It was pretty full. So I've been moving into more of a consulting advisory role with a bunch of digital health startup companies, and specifically spending a good amount of time with Redesign Health, which is a venture studio based in New York. We can talk more about that if you like. And just there's just so much out there, and it's my approach is it's hard for me to focus on one thing. So why not focus and get breath going? So that's a little bit about me. Less about digital health, but what I was really kind of took me in the news yesterday morning. And it was actually whilst I was on a phone call with a colleague who works at Advocate Aurora. He's one of the leadership there. And he said, Raj, I've just come out of a medical exec meeting, and we were just informed that Advocate and Atrium are going to merge. I was like, wow, I literally had to sit down and take a deep breath and say, wow, this is like, having come from a health system that went from 3 hospitals and $1.5 billion to $8 billion now, Jefferson, right? It's a $27 billion organization across 5 sites. And then there was another news article about a real focus is going to be around digital transformation. And it's hard enough for a small hospital provider group, community sites to think through digital transformation. I'm just overwhelmed by how this is going to happen and how the digital health industry is going to think through this about getting relationships with such a large health system.
Yeah, an interesting one. And there's quite a bit of commentary back and forth about whether these trans-regional mergers make sense for hospitals. And there have been a couple which have done some stuff so far, but yeah.
And a couple which haven't worked, quite frankly. There's been...
absolutely. Well, wouldn't be the first time mergers haven't worked in healthcare. Jess, what have you been up to?
So it's interesting. So I was at ATA, the American Telehealth Association conference 2 weeks ago. And it's I feel like there's been this weird layered effect of things that have kind of just been happening around that. So it's the sentiment at ATA, obviously very focused on virtual care, what's happening with state licensure, what's happening with reimbursement, all the policy stuff around that. John, I want an update from your side of the table over there. But what was interesting, I feel like there's this change that's starting to happen right now with these digital health companies that we've come to know and love over the years. So I don't know if this is in reaction to what's happening on the public market or what's happening with funding or just the evolution of business model, but it's a couple of pieces of news that have come out recently. It's interesting. So it's earnings season too, right? So Teladoc reports earnings, terrible. Things are not going well over there. Teladoc, we know about their write-off with Livongo, all of that. Meanwhile, Hims and Hers beat. They're increasing their revenue guidance for the year. And I know those are not the same thing, but it's interesting that one model seems to be working and the other model does not seem to be working. At the same time, Vita Health announces that they are starting to prescribe medicine for both mental health conditions. So their digital health chronic condition management company, fully integrated, right? In that whole diabetes, mental health space. They're going to be prescribing drugs for anxiety and depression. That's it. And then on the other side, they're prescribing diets, continuous glucose monitors, blood glucose monitors for diabetics, and testing like A1C level testing for those who are more in that cardiometabolic part of their business. But it's the big takeaway that's starting to kind of bubble up here for me is it's where is this? There's this real mix of, what used to just be digital apps and coaching on your phone, whatever, is really starting to morph, I feel and getting into more care delivery than it ever has been before. And I know, Matthew, you and I have kind of been watching this, and talking about that whole idea of continuous clinic and just these business models expanding. But it's I really actually feel we're starting to see, what used to just be digital merge into digital plus, some sort of in-person hybrid thing. And then what used to just be prescription drugs merge into actual care delivery like Hims and Hers, or online pharmacy. I interviewed Z Reitino, the CEO of Ro, on stage at ATA. I had no idea that Ro had an online cash pay pharmacy with over 1,000 generic drugs that you can just get prescribed to you and pay for cash. I mean, so it's I feel we're starting to see, and I said, I don't know if it's because of the market and people have raised money and now they've got to, prove those numbers, but I feel we're starting to see these models really gain some traction. People are starting to expand out from where they were before.
Yeah, no, a fair amount of conversation needs to go on about what this thing looks like in the end. Although, that continuous clinic thing was brilliant. I wonder who brought that up. Anyway, all right, Jen, what have you been looking at lately? And then after that, I'll give you a bit about what I've been looking up to, and then we'll dive into Digital Medicine Society. Sorry, gonna get your name.
I can't help but start there because everyone's missed the big news, which is Dime turned 3 this week. Which was
happy birthday!
Thank you. If only I was actually celebrating my own 3rd birthday, but sadly we're not there. So Deven, we were together in Boston, if you remember, when we got this thing off the ground 3 years ago, in the before times. And what's really interesting, we launched Dime with a view that none of this is successful unless we have trust. So Deven, we want to come back to what you were highlighting because that's has been a hot topic in our community. We've been talking about privacy and protections now that there's so much digital data that lives outside of any sort of privacy protections. But now we have this case example and it is urgent and it could really harm people. So we've been talking about that a lot. The other piece in better news is obviously seeing the Affordable Connectivity Program go through earlier this week, right? There's always this question of what are we doing with digital, Jess, similar to, what's the plan here? And the question's always been, how are we going to use this? Is it, we're at a fork in the road? Are we going to use it to double down on the digital divide? Or are we going to use these flows of data, these new tools, this ability to overcome maldistribution of, experts who can provide care and the folks who need it, right? This is a really good step in that direction, that we may be able to improve access. And in fact, the intent of all of this to ameliorate long-standing healthcare disparities that we haven't been able to move the needle on at all, there may be a pathway here. So that's what we've been thinking about this week.
It's awesome.
Fantastic. Well, I think I'd add a couple of things. One is that earlier this week, the for-profit hospital sector, which is not merging as quickly as the non-profit sector, as Raj put out, they had done, their stocks had done pretty well, and they HCA and some of the others had a big collapse, basically because the cost of labor, had increased dramatically. And we are seeing, big picture economy-wise, and the stock market, the current stock market collapse or correction or whatever you want to call it, it had ramped up ridiculously because of the amount of money that had gone into the system during the pandemic. And I think it was the right thing to do, right? We've shown that, essentially Keynesian economics is still alive. If you pay people for doing nothing, as we did during the pandemic, you keep them from heading into poverty, you keep the economy from collapsing. I think it worked. Obviously, we're now dealing with the combination of the inflation caused by that and the supply constraints and as the supply chain got screwed up. That has all come full circle. And then with the tightness in the labor market, especially in healthcare, we're seeing some real pressures there. And this is happening to the incumbents, the big incumbents. It's also happening to the, to the startups. And many of the startups are now fighting over acquiring, therapists and online doctors and all the rest of that, as much as they are fighting over patients. So one reason, by the way, for Teladoc's bad numbers was that the customer acquisition cost of patients was going up, primarily because Cerebral was spending so much money on advertising. And since we last been on talking about digital health, Cerebral has now sort of come up into trouble and stopped now with ADHD, prescribing ADHD drugs while it's being investigated by the DEA and the stuff heading there. That's one big piece. The other piece, which I just would mention, is there's an article by Robbie Pearl and I'm blanking on the guy who runs telehealth at Intermountain. And they had an article about all the different things, going back to that continuous clinic idea, all the different ways that Intermountain and Kaiser are now using essentially telehealth, especially consults, chronic care management, hospital home, all this great stuff, and how it's all fantastic and how it's saving money and improving care at those two systems. And then the rest of their article was how it was going to spread everywhere across America. And I went, the first part is scientifically brilliant, and the second part is science fiction, because we've always really struggled to get those kinds of, population health innovations, which are technology led, to get to other systems like the Advocate Auroras or Advocate Health, whatever it's going to be called now, or Atriums, or many others. So I'm always wondering how we get the level of innovation that we see in digital health out of two places. One is out of the already capitated systems like the Kaisers and the Intermountains, which are care about population health for those reasons, because they're not primarily fee for service, or the places that Jess mentioned, right, which is where it's a cash pay consumer business, where it's easier and simpler for people to go to Row or HIMSS or wherever. So to me, that's the ongoing issue we have, and the companies that are digital health companies that are supplying somewhere in the middle, which is where the Teladocs and the Amwells are suffering from not only being massively overvalued during the boom, but also, are now suffering from having a bit of an identity crisis about what they're providing and to whom. We can blame Raj because he was one of Teladoc's first big clients, right? Or one of them at Jefferson. But it always seems to me is that quite in a down market, investors aren't quite sure where that's heading, and some of these companies are having identity crises, and some of them are now trading down around their kind of cash on hand value. So it's a very interesting market. We'll see what happens. All right. With that, Jen, let's introduce you a little bit to the audience. You obviously, the most important thing about you is that you rode for two different countries in the World Championships for both of them, right?
Yeah.
Yeah, I mean, these people who come from England and become American, it's very confusing, how you get signed.
I was always both. Ask my very American mom.
So always have that. And then, I assume rowing, like basketball, you're getting paid multi-millions and decide to retire into not that kind of sport.
We take basketball under the table with the big paychecks that you get from rowing. I mean, think about it. Like, think about all of the pay-per-view that you have done for rowing. That came right to me.
Oh, fantastic. So how did you end up transitioning into Dime and into the digital medicine world?
I mean, completely by accident. I'm a chemist. My research was in liquid crystals, and I think I'm looking at you in an LCD screen now. So that should sort of date the science, but also it was very applied. It turned out quite well. So, I mean, I retired after the 2008 Olympics and always thought that with a good degree and, I did grad school and been to the Olympics, that I'd be quite employable. But the economy was in the toilet, so ended up going and working in academic research because I felt like it was a pretty stable environment. So ended up working at Penn, and it was fantastic, especially for someone who grew up in Britain. It was a very different healthcare system over here, but I was doing health services research throughout the passage of the Affordable Care Act. And for someone who had had this career as an athlete, and a lot of people struggle to transition into like a more traditional career, I felt fired up every day. It felt as important to get up and do this work, and I was as jazzed about it every day. Throughout all of this, sort of technology comes to the fore and led us to ask the question, we've been banging our head against the wall for decades. There are pressing and persistent challenges across the entire care continuum, research, care, public health, so on and so forth. And we have this digital era that's coming to bear across industries. What the heck are we going to do with that opportunity vis-a-vis healthcare, vis-a-vis people's lives, right? Are we going to use this, as we were saying earlier, are we going to use this to ameliorate healthcare disparities or double down on the digital divide? Are we going to do precision medicine, or are we going to do the surveillance economy, right? We're at this fork in the road, and that really was the impetus for Dime, coupled with there wasn't anywhere that we could see, and I stay true to this, although I'm always happy to be corrected, that brought together all of the experts. So from citizen scientists and cybersecurity experts through all of the physicists and engineers and data scientists, clinical scientists, healthcare providers, executives, payers, investors, regulators, funders, right? Unless we all have a shared idea of what we're doing here, Jess, back to your point, like, what does good look like? Like, what are we even doing here? Like, are we just shoehorning 500-point solutions into an already really complex model, or are we trying to change things? So that's our jam, and that's what we've been working on for 3 years now, as I mentioned earlier.
Fantastic. So tell us a little bit about the shape of the organization now. You mentioned the kind of constituents you're working with, which is everybody. But tell me a bit about the scope and shape of the organization, and tell me about your current initiatives.
Yeah, so we launched as a first and foremost a convener, right? Bringing all of those different voices together, and not just from different expert groups, but from across the world, right? The definition of a heartbeat, or what good looks like when you are caring for a human, doesn't change. And especially on the research side of the house, we have to be able to transcend regulatory and payer and HTA bodies, right? So we've always had this sort of very bold view of our reach. The way we wanted to sort of pursue our mission was not only bring the right people to the table, but then what are the hardest challenges? What are the things that we don't have an answer to today? So we have a thriving research program. We've been very impactful there. That's continued to grow. It's been intentional. We've gone from more framework-based to applied as the field has evolved. And then what we've recently launched actually is our education programming. So we always wanted to say, I'm here with the right people, right? It's not nonprofit land. I can talk about a flywheel. So you have the community first, right? And then you solve the most pressing challenges that those folks tell you that they're having. And like, what belongs in the pre-competitive space? Not everything. Some of it's your own business challenge, and good luck to you. But the rest of it sits with us. And we've tackled those. And then you don't sort of close that flywheel until you say, are people aware of this? Do you know how to do this? Do you know why you should do this? What's the value proposition here? What does good look like? And you actually take the time to communicate and educate that. So recently we've launched our first CME program for physicians to start to get really comfortable with digital. And we've actually launched some corporate learning offerings to our life sciences colleagues with a really vibrant sort of portfolio and curriculum of different, very, very applied learnings that people can pick up and implement today, we can't keep moving forward with willful ignorance. Oh, I didn't know there was bias in this. Oh, I didn't understand what the privacy restrictions were. Like, that won't do anymore. It's unacceptable. We know what good looks like. So not only are we trying to forge ahead with defining global best practice, but actually taking the time to make sure it makes it into the hands of people who are under enormous pressure to apply these things today and face enormous opportunity cost. Let's help them get it right. So that's how we've evolved over the last few years. And the education piece is new, and we're really excited about it.
Well, congratulations on splitting that up, because it's tough for any organization to get anything done that's new, but also then having to go and sort of sell that through to or get that through a whole coalition is exciting. Who do you think needs that the most, right? So you've got a pretty, by this stage, Jess and I spent a lot of time looking at this pretty vibrant, well-funded digital health sector. Yeah, maybe it's hitting a big bump at the moment, maybe not, we'll see. But which has grown steadily over the last decades. I mean, there were 500 people at the first Health 2.0 conference 15 years ago, and probably on the way, there'll be 6, 8, 10,000 at the next upcoming HLTH, maybe, maybe not. We'll see. But I would look, if you look across the whole of the healthcare system, yes, there have been some wins. Yes, there have been some places where this stuff has taken off. But I don't know how big, you can argue with me, how big the impact has been across the board. Who do you think needs it the most? Who is it? Providers? Is it payers? Is it regulators? Is it pharma? Who needs it the most?
You sound like our comms team. They're like, Jen, who are we speaking to? And I'm like, don't get it. It needs to be everyone. And then they just sit back in their seat and bang their head against a wall. But I do. They're
asking you to prioritize, I think, and so am I.
Yeah. I understand the question. I just, dispute the I dispute the decision I have to make. I think it ebbs and flows, and I think it changes, right? In the current environment, and you mentioned this, right? The AHA report that came out last week, and we see that 1/3 of hospitals across the US are operating net negative right now. That is not a sustainable future. There aren't enough healthcare providers. Drug prices are through the roof, and supply of routine medical equipment is incredibly expensive in the aftermath of the pandemic, right? We have to figure out how to do this better. If there is a healthcare executive in the country who is going to bed without worrying about staffing, you're out of your mind, right? So I think, again, Jess, going back to your reflections on ATA, right? It's not just nibbling around the edges. It can't just be virtual first care off over here. We have to be thinking about, if there's 40 to 60% of capacity in the physicians who are still choosing to practice, we have to figure out how to unlock that, right? We have to figure out how these other modalities of care that patients and providers are opting into becomes part of the fabric of healthcare delivery as quickly as possible. And given that drug prices are one of the main drivers of this sort of imbalance of care costs, we have to stop thinking about research being over here, right? There is no reason why data doesn't live locked in a manila folder in a file cabinet anymore with only the principal investigator or the practice manager having the key. We should, and this is, Deven, why I love having you here for this, we should figure out how to make it appropriately accessible to people who have been authorized to use it, so that all of these drug development costs are baked into sort of healthcare delivery, that it is that learning healthcare system we've been talking about for decades and haven't got there, because the data liquidity is going to be the thing that takes us there. So as I've completely dodged the question, I think right now it's healthcare executives who need help now more urgently than anyone else. 3 years ago, I would have said pharma was going to drive it. Now I think healthcare has actually blown through the research side of the house.
All right, good. Well, so that's I'll take that stance. Oh, that was you identified somebody, which is great. I think that's fascinating. I mean, and opening this up, I mean, I wonder if you talk about this transition, and maybe, Raj, maybe I can drag you into this, but we have spent a lot of time on THCB Gang going, is this a transition where we help the current incumbents figure it out and do a better job, versus is this Amazon replacing Sears? Do we figure out and that's kind of inherent in Jess's question, in Jess's comments about how we do build this thing. So again, you need to get the incumbents to be more aware of this stuff. But if I look at something like this big merger, right, between Atrium and Advocate, Aurora, And I'm going, you're going to do this big merger. I don't get to see the point on a regional scale. Are they really going to transform and become like this sort of national telehealth hybrid organization? Is that how it works? Does Amazon do this? Who does that? So I'm still on that point confused, but obviously they have more heft and money than for the moment.
Let me unconfuse you.
Okay, please unconfuse me. That should be easy.
So I think both Jess and Jen have said some really important stuff that, when I think back to a decade ago, 15 years ago, when Teladoc was set up and a few other companies, this is all stuff at the edges, right? This was care delivery is owned by our healthcare delivery systems end to end, from flu shots to post-acute care and everything. You go to Penn, you go to wherever, right? That's where you go and get everything done, right? And what we saw is that these new entrants, digital technology companies started kind of getting more traction, right? And more traction, but was still healthcare delivery, I would say, even pre-pandemic, was still owned by the systems, right? And then what happened with the pandemic, it was like, I think I've told the story on one of these previous web things that we've had, is my patients got an opportunity to have a televisit, right? It wasn't like, well, he's just available at 2:30 on Wednesday. It was like, he's available at 2:30 on Wednesday. Do you want a televisit, or do you want to come see him in Center City, Philadelphia, right? And that kind of changed the game, right? And I would say what we're seeing right now is an unbundling of what we consider the traditional healthcare delivery system, right? Why does Jefferson need to give flu shots? Just stop, right? We don't, right? We don't make any money out of it. We're terrible at it, and you don't need to do it. There's better places that do that. You go into CVS and then you're going to go and buy some Cheetos and some shampoo and all that kind of other stuff, right? So they'll make money out of it. And so I actually, what you said, Jess, about these companies, some of the earnings reports, and they're diversifying how they're thinking about it. That's absolutely what needs to happen. And why that needs to happen, and going back to your question to Jen about who needs to know this the most, I always go, and Steve Klasko, my mentor, my boss at Jefferson, says, part of the reason why change doesn't happen is because the patients don't stamp their feet up and down and demand it, right? Would you ever check into a hotel where you went to the desk and they said, wait in that chair for 3 hours and we'll get to you when your room's ready, right? I mean, you just don't do that, right?
And you don't know how much it's going to cost either.
Yeah, exactly, right. You don't have the pre-auth and all that kind of stuff, right? But you just sit there and wait. We put up with it, right? And so this is the power of the consumer, which we've seen in every other vertical and is now becoming realized. And so going back to the advocate thing, and this isn't specific about advocate, but that's a defensive approach, right? To dumb down. We don't know what else to do, so we'll just get bigger, right? That is what's happened here. I mean, I'm sorry to be so blunt about it, but that's essentially, or there's we're going to compete. There's the Providence approach. We're going to build our own digital health portfolio and so forth. But it's one or the other, and it's a frenemy approach, right? When you say we're going to partner with all these other companies, and maybe I sound a little bit like kind of Alice in Wonderland right now, but how can we figure this out together for the sake of our patients and enable our providers to be able to do what they need to do for the sake of our patients? So let's put those kind of politics aside, and let's really unbundle the healthcare delivery system that works from a cost, access, quality perspective.
I just don't, I'm less sanguine, I'll tell you, about telehealth and some of the reimbursement models behind it being as clear and as reliable of a driver toward greater efficiency, less care, more responsiveness to the consumer, based on an experience that I recently had. So had some genetic testing done by Invitae, because that's an employee benefit that I get, which is terrific, which includes genetic counseling as part of it. So turns out I did need to get some follow-up care. So I went to academic medical center, who said, oh, first you need to have a genetic counseling appointment. So well, I have one. Here's the report. No, you have to have one of ours. Cha-ching, visit there. Second off, it's pretty standard with the particular issue that I have, that there's like a course of kind of preventive monitoring that happens. But instead of being able just to get directly referred to the two things that I need to do on a regular basis, nope, I had to have a visit, a telehealth visit with the doctor in order for that to happen. because cha-ching, that visit can now be billed. So it's less about orienting care around convenience, non-repetitive tests, getting from point A to point B quicker than about, oh, now I can bill for this thing. So this thing is now going to get included in the flow of what happens for this particular patient. And this is obviously just one case example. And I'm fortunate that I have good insurance and I can afford all these cha-ching, cha-ching, cha-ching that are adding up, although I do have a pretty high deductible. So some of this is on me. But it's just that it still isn't the kind of care experience. It still isn't about how we do what's best for the patient always. It's also about, I've got a facility to support, and here's my revenue model, and here is now how I can bill for it under telemedicine, and that's how it's going to go.
So I want to chime in here if I could real quick, John. I'm sorry to cut you off. So this is just maybe food for thought, but this was interesting to me. So at ATA, that conversation I had with Z, who's the CEO of Roe, the whole entire conversation is about Roe's business model, and it was they're talking about it as direct to patient care. That's what they've named this. And it's very much, and Raj is nodding his head, it's very much like Steve Klasko, Hey Montanasia health assurance model, where it's this idea of this is not going to be a flip that gets switched overnight where everybody's just going to pay for their care. But Z's point is everybody's already paying for their care one way or another, through reduced wages, through taxes, through whatever. And their model is just kind of what they're trying to do is put the consumer who actually has the dollar next to the care that they want to buy without any middleman in between it at all. And he's not, I mean, obviously, this is not something for everyone, but the way that their model is starting to shape up actually gives me a lot of hope, because it's not just about the patient having control over their spend. It's also about the provider, in this case, Roe, stripping out costs so that it is affordable. So that online pharmacy that I mentioned with their generic drugs, they don't have to go through the same type of middleman after middleman after middleman that a health system or another prescriber would have to go to end up with that, or even an insurer, to end up with a price that pays everybody along the way for that. And then they're doing similar things. I mean, and I know that this is very like, okay, for the affluent healthcare consumer, right? But the way that looking at it as a case study of what can be done in their case, fertility care, or in their case, some of these other things, strip out the cost that's already inherent there. So Deven, like, let's test you 4 times. And then it's like, they're trying to, and I admire the fact that they're piloting it, and it's not perfect. You can see where definitely not all care, but some care can go into a model like this. And I feel like there's a point where you can continue to prove that. Like, why not go further upstream and unbraid the dysfunctional relationship that has existed between payers and providers and patients from the very beginning? Like, why not look at what it could look like if you did take that dollar and free it from that triangulation?
I don't know, guys. I think I struggle a bit, right, Raj? When you say, if patients were stamping their feet, things would be different. That's the incentive. They'd vote with their feet. And I think patients have been stamping their feet for a long time. Things have been really bad for patients. Like, you think of the burden to the patient and the care partner to do what Deven described, and also, get your records, all of these sorts of things. Yes, we've been screaming and shouting for a long time. And quite frankly, if the purpose of our industry is to care for people, we shouldn't have to force people to wage war in order to turn the ship. I also think, Deven, your example is incredibly good. I think the bit that gets me is we're assuming that the strongest driver of change is the pursuit of income, and it's the pursuit of fees that's driving things. I think the staffing crisis is going to be what changes things. I think supply costs is going to be what changes things. It's less about, continuing to bill. You can't bill if you don't have the doctors to do it, right? What you want to be doing if you are an academic medical center is you want to be doing very complex, high acuity care. You want to do the sort of load balancing that Raj was mentioning. You don't want to be doing injections at Jefferson. For the physicians and the clinicians that you have, you want to be billing them where you can. I think that we might see what Jess described as the winnowing down of costs that we're seeing in direct to consumer across the board, because the costs are unsustainable regardless of who the payer is. I don't think there's going to be enough ways to jerry-rig the billing.
Well, I mean, it does worry me that you've seen, discussion of value-based care, and even in the Advocate Aurora Atrium, too many bloody A's. Even in that merger discussion, we're doing all this value-based care stuff, and it was some ridiculously low number, like 400,000 people across, 28 states or whatever they are, who are now in some kind of ACO. But it worries me that it comes down to, is telehealth, and this was the 88 conversation, is telehealth emergency going to be extended? Are we going to have the ability to do more, to bill Medicare for more RPM? Are we going to have enough Medicare Advantage to pay people out of a different bucket that isn't strictly adhering to the current fee schedule? That stuff has changed. Every time Jeff Goldsmith comes on THCB Gang, he says this stuff's never changing. I've been hearing about this for 35 years and it's never changing. And so I share Jen's concern that people are just going to continue there with their hands out, and it's just another thing to bill for. It's just another technology to bill for, and it's not really being driven in the way that will improve patient care overall. And I think that's the most likely outcome. Go on, Raj.
Can I just bring up something on the workforce? It's funny, I don't practice anymore, but I got a letter from the Pennsylvania State Board of Medicine 2 days ago that said that anyone that had got an emergency license in Pennsylvania, through COVID, and I did in New Jersey and Delaware, those licenses are going away, right? By the end of May, those kind of cross-state licenses are going away. And I was just like, why? Let's just try and think about it in common sense. Let's put the funding and all that kind of stuff. Why is this decision being made? And can someone help me with that from a common sense perspective? And that's just going to exacerbate what you're talking about, Jen, from a workforce perspective, surely.
Yeah.
So let's go ahead, Jen, and I can read out the completion. Sorry, go ahead, Jen.
I was just saying, I don't think we can answer that one from a common sense perspective.
Let me say,
answer from a common sense perspective today. Where is Roe v. Wade going? If that can exist for decades, and Jeff Goldsmith is like, the payment model's never changed, you never know. I don't know. The common sense here seems to have flown out the freaking window.
Well, there's some politics behind that we all know, but I think just a couple of things. So Chrissy Farr had a good piece today about the experience of a telehealth doctor, and there are number of doctors who are licensed in 10, 12, 15, 30 states, which is a ridiculous thing to get done. And then Kim Bernard wrote a great piece on THCB, which was about essentially Roe v. Wade. But what he pointed out was that roughly half of all abortions now are pharmaceutical. They're not medical clinical, right? And that a lot of and we should get back to where Deven started this conversation. A lot of the issues around that are that it's being delivered. It's being prescribed, medications being prescribed by, in some cases, people in other states, doctors in other states, in some cases, doctors in other countries, right? And now we're going through the mail system, and you run into with all these new regulations that may get, when Roe v. Wade gets rolled back or gets cancelled or whatever it's going to be, you're going to end up with a lot of issues of actually enforcing this stuff, because half of it, we're talking about privacy. Practically, how do they actually figure it? How does somebody who wants to enforce, no abortion actually do that? I don't know how that works if you're talking about, stuff being sent through the mail and people doing it in their privacy of their own home. Deven, do you want to say a little bit more about, how it's happening, how you think that's going to work out? Because that also, Kim also brought up, it's kind of crazy that we have medical licensing for when you can get a medical intervention that's like tip of the spear like that, which is being essentially delivered at a mass distance.
Yeah, it's not the data stuff is my area of expertise. This is not my area of expertise. I do think it's interesting. I do think you will see some states take steps to prohibit, for example, physician, there might be some tightening of telemedicine types of initiatives with respect to certain types of care. Some states would call it out, right? And abortion, you can't, no provider licensed in my state is permitted to prescribe abortifacient pills or pills that can be used as abortifacients to any patient in the state or outside of the state or be at risk of losing their license. It's not, I don't know that I've heard that, but it's not at all outside of the bounds of possibility, right? That this expansion in telehealth, ordinarily would be enormously beneficial in a circumstance like this, but the same, sort of policies that helped to open it up can also be deployed to shut it down, either selectively for certain types of care or across the board because of the possibility that those, loosening of restrictions and loosening of interstate, state licensure issues is going to lead to people being able to more easily cross borders to get care without ever getting in their car.
So let's go to the data point though, because some of this is around, I know you raised it before, and we've seen people on talking about, it's, if you are period tracking, you should delete the app or whatever. There is, I've seen various descriptions about, is this hysterical versus is this, coming down the path? What is the sort of state of play around a lot of the stuff is non-HIPAA generated, protected data that's collected and it's collected in different ways. What's the state of play, do you think, gonna be if in a post-Roe v. Wade world where you have, people who are doing things that are theoretically now illegal in those states, but the investigation of them is going to be potential for accessing data sources. And it seems to me that you've got a potentially sort of legal and policing minefield here. How do you, it is your area. How do you think it's going to think about playing out?
Well, I first of all, I think to the extent that some of us might have thought of some of the laws that I have heard of as, unlikely to happen, right? That seems rather hysterical. I think we can set to the side the notion that completely dystopian laws are beyond the pale. Like, I think it's absolutely possible and will happen in some parts of the country. The other thing that strikes me is, you have this sort of, as you pointed out, Matthew, you have the HIPAA covered world. Surely the data is more protected there versus the non-HIPAA covered world, the app world, where it's, commitments that the FTC can enforce and maybe some state law in certain circumstances. The problem, though, is that HIPAA is actually not very protective when faced with state law reporting mandates or subpoenas or court orders to release data, or just a facility that gets asked by a medical provider about healthcare facility that gets asked by law enforcement who's doing an investigation and takes advantage of one of the permitted disclosures under HIPAA for crime committed on the premises, for investigation of a crime. Like, there are all these sort of permitted disclosures. They're not mandatory disclosures in HIPAA, but they are permission slips that I don't think at all envision the environment that we are about to step into. They basically, it was a negotiated rulemaking where facilities said, well, we have to be able to disclose if we get a subpoena, and we have to be able to disclose if law enforcement is asking us questions. And so there's this entire laundry list of ways that HIPAA enables the cooperation of healthcare facilities with law enforcement in a way that's not going to go well in certain parts of the country, given some of the state laws that I've seen.
That was, I think, the most pessimistic thing I've ever heard on THCB gang. I'm not feeling optimistic about this. But you're dead right. I mean, we have literal medical insanity, right? Which is like people with ectopic pregnancies are going to be forced to carry, which kill you. My father, by the way, who was a obstetrician gynecologist, his greatest claim to fame is that he, this is irrelevant to the point at hand, but actually, pretty impressive, is that he and his favorite anesthetist felt there was something odd about one of their patients who was at term, and they did a C-section, and it was an ectopic pregnancy C-section, and he got the baby out alive, and the mother was alive. And the mother alive. And that And he said that was the
How uncomfortable must she have been?
God knows how that managed. He said I cut in and I couldn't find the uterus. The baby was so but that was what that was 1 in a million. God knows how many million, right? We know that obviously that's hopefully nobody in Indiana or wherever the hell that's now the law will actually be listening to this and go, oh, it's okay, Matthew Stanza. Can sort it out. But I mean, you have that level of stuff going on. You have now, I think, the Louisiana law, which is suggesting that any fertilized egg is now a person. So God knows what you do about IVF. That situation. I mean, I don't know how you do this, but you could imagine some really bad dystopian shit coming out of the path, unless I don't know. Just
right. And I guess my point is the fact that these laws will exist already, will exist, will increase. HIPAA does not save us from them, at least not as currently drafted. Could it be amended by this administration to tighten some of that stuff up? Yeah, I think it could.
But presumably that would need some number of votes in the Senate that we don't have.
No. This is HIPAA is mostly in regulation. So it's the regulations
you could amend it,
that lay out. You could go through the regulatory process. It's not quick. They would have, I think, grounds to do an expedited rulemaking to sort of tighten some of these permissions up. But it's tough because there are federalism issues in play around, if a state wants to require, in the name of public health oversight, a certain reporting of certain data, or to make something a crime, can the feds by regulation step in and prevent that? And that is where it does get complicated. Is some state will sue, and it will be some amount of time before that gets resolved, and it could land in a place where, in fact, a court saying the federal government cannot, by regulation, impose, override states' abilities to, oversee healthcare in their borders. On the other hand, there's already a preemption provision that HIPAA does preempt weaker state laws. So it's a very interesting, make a very interesting law school exam, to be honest. But unfortunately, it's not hypothetical necessarily. It very well could happen, which makes me glad that I am a woman well past reproductive health years. So.
Yeah, it's. I think it's terrifying, and you've also then got the sort of further can of worms, right? You have companies who are saying we will pay for our employees in different states to receive this, to travel or whatever. You can imagine that, and now we have Texas where anybody can sue anybody for helping. You can imagine this stuff goes, down a very bizarre and frightening path, and we'll just have to hope it. I'd like to say cooler heads will play. I don't see where it comes from.
So much for the power of the patients demanding care and changing things. Not to come back to that, but
right. Vote with your feet. Where do you go?
Exactly.
But this is the thing. I mean, and we can go round and round in circles with this, but the reality is none of this is going to reduce abortions, but it is going to reduce the number of women who die in pursuit of them, the number of people harmed in pursuit of them, and also all of those families who are looking to have a child of their own when they're not able to, right? The net of this across the board is terrible. And, we've lived through this mis and disinformation during COVID, right? There isn't a huge amount of trust in these systems. Like, if we don't think this is going to further erode trust in healthcare providers and a system that's intended to care for people in data that, God forbid, and it probably will, while we're on the sort of downer subjects, the next pandemic to hit our shores, if we want to, take a data-driven approach to that, no one's going to trust you to do it. Like, all of the decisions that we're making now, I think, have absolutely no hope of achieving their goal. And all that we do is sort of erode trust and confidence and opportunities to actually care for people, which again is the entire purpose of our industry.
Yeah, what she said.
All right. Last 10 minutes, I'm going to move us to something less depressing, but not much less depressing. Because I agree. I'm looking at this and going, you look at it and go, the way the Supreme Court got to 5-4. But anyway, let's not go there any further. Anyway, Let's turn to the sort of the big picture economy / stock market / digital health issue.
I thought you were trying to go to a happier place.
It's happier than where we were just at.
Why would you bring us back
Happier? I didn't say it was happy.
Clearly, Matthew's really, really short.
I'm going to raise the tone here and talk about something exciting. How about the digital health marketplace and how that's crashing? Like, oh, okay, let's do that.
Here's my question, Dory. All of us watch this pretty damn closely. And Raj is now working with a bunch of companies, and I am too, right? Who are out there. It seems to me there is still private sector funding for people who believe that they can build companies that can either take advantage of, go and help the current incumbents who are still spending a lot of money, it's still a huge market, or can come in and whether it's a Hims, a Row, or Next Version, Teladoc, whatever, do something that's different, right? We're seeing that a lot. And even though the market was, at its height for digital health back in February and March of last year, and it's now 90% off for some of these companies, we still saw that massive funding last year, and there's still a ton of money on the balance sheets of these private companies, right, who potentially could be doing more with it. So how do we feel this is going to impact the business of digital health that we're in for the next year, 9 months, year, 18 months? Do we all end up on the beach out of work? Do we see these companies still building the way that Netflix and Amazon were building in 2002, 2003, and keep going, and that will, once this little market panic is over, there will be a big industry here? What's your sort of take on how this slowdown, this stock market crash is gonna actually impact the industry per se? Raj, you gave up being a surgeon, which a surgeon for obese people.
That was a lot easier.
Which I can say was a fairly safe job.
It was. Yeah.
So
look, I'll kick it off with, I know we're talking about digital health, and we've talked about Cerner on this program before as well. Cerner stock's flat, right? They're still going to get acquired by Oracle. They've still got a market cap of 27, 28 billion. That's interesting, right? I mean, they're taking a lot longer to get the acquisition done, right? I don't understand that, quite frankly. So it's not everything that's gone down, and that's part of the mainframe that runs our health systems, right? And then in terms of, I have a pragmatic view, which is probably not a popular view, in terms of the valuations and from a private company and all these new companies, and I hear about 3-5 of these a day, and the founders raising this and that and all that kind of stuff, right? I'll go back to Vive when we were at their, there were 400 companies in that exhibit hall, right? How many of those are actually fully implemented in our healthcare delivery system, right? I'd actually say to the investors, stop investing in any new company, right? Invest in those 400 companies, do the follow-on, make those work, right? That's where we need to figure out. There is enough innovation in digital health, right? There is enough. You take all those companies and put them across every single healthcare delivery system in this country, we have transformed, right? That's not going to happen, right? Because people like money, right? And people want to put more money in to see what happens, right? But that's the pragmatic approach. I don't know if that answers your question, Matthew, but it's something I've been thinking about.
Well, I mean, that's an option. It's hard to, I mean, we all see new companies coming, being formed every day, and people leaving and starting a new one. I was talking to one today doing, working on hair loss, which not that I would be a target market or anything. And there was one which, I just saw come out where somebody raised $9 million to do, $15 million to do something around the, Jessica, I haven't talked about this one yet, but some in the order of helping people make, get money back when they make healthier choices with their credit cards.
It was like, I'm like, wait, didn't we live this with the Visa gift card back in the day? Is that not the same thing? I had to read that twice, and Andreessen backed that. I was like, what is this? Why?
I mean, but what I'm saying, what I'm saying is that there is still, the venture funds still have a lot of money that they've raised and they haven't deployed all yet. There's still a lot of companies which look kind of odd and aren't doing what Raj is saying, aren't currently implemented need to grow within the current healthcare system. They're out there, are going to be keep being founded. But I mean, I guess maybe the simple question is, if we get a health in the fall, or next year or the year after, are we going to see the same level of number of companies and number of attendees there, or is it going to be where it was in 2001, where some of those e-health conferences were huge, and then Deven and I were at them, and then sort of kind of disappeared? Jen, do you have a sense of on where you think the flavor of the industry is?
I mean, I'm inclined to agree with Raj. I'm not sure that it's the incumbents that we need to be propping up, but I think that you're actually going to have to show that you're providing value to the healthcare system. What a crazy idea for a health innovator, that you actually have to be able to support that. And we've seen, like, biotech's a great example, right? We've seen it go up and down, and biotech hasn't gone away. Thank goodness, right? And it's going to ebb and flow, but yeah, we're moving into a different moment. And I think you are going to be asked to prove, both to the people you are selling your product to, who are going to become more educated and become more discerning. Hopefully we have a part in that. But also the investors are going to become more savvy, and they too are going to have to become more discerning. Matthew, you're exactly right. There's still some money in the pot to dish out. And Raj, you're exactly right. I don't think we need 4,000. 400 is probably fine, but let's get the right 400, right? Let's start to think about not having 400 point solutions too, right? It's not just the value that you as an individual organization and digital solution offer, but how do you integrate into this very complex environment, especially one that's likely to become more complex before less, as we think about a hybrid, or, let's crack out all of the different buzzwords, omnichannel approach to care, right? That I think is going to be the differentiator, is you're actually going to have to prove your worth.
I can't believe Jess hasn't said the word on the channel yet. You got there first.
Well,
it's off my bingo card at this point.
Like, so
I
done.
moved past it. Like that was so like 4 months ago. No, I think if I'm going to weigh in on this, I'm going to say this, and I don't think we've even seen the beginning of this yet, but it's M&A all day. And we've been saying that since the beginning of this year. And I think that, what I was trying to articulate at the top is that we're seeing this like Frankensteining together of like companies or service lines or whatever as these companies. Maybe they're not the 400 that were at Vive, but like we are seeing, there are certain companies that, and if I'm looking back, and Matthew, I'd be curious to hear what you think about this, but it's like, if I look back at the last year and a half, the companies that raised those mega rounds, the 100 million plus, and then followed that on with like an additional 50 or whatever. I feel like those are the ones that have had like the money backing them. And those are the ones that are going to start acquiring these smaller companies and integrate that in. And we've already started to see that. From that chat I had with Ro, I know they acquired 3 businesses in the last 18 months. And you look at a company like Headspace, what they've acquired. You look at, we haven't even seen some of these other really well-funded companies, Vita Health. What are they going to add now that they can prescribe? What's Transcarent going to go and buy? You can keep going. There are a lot of really well-funded companies that can start to absorb this stuff. I just don't think we're there yet, because I think that all of those companies that got those really fat, average $35 million Series A rounds, okay, they're still burning through their runway. In fact, I talked to one just yesterday, and they were saying, they're like, we've got a year and a half. And so and it's like they had just raised an A, and it was a $20 million or so A. We got a year and a half. So I think we haven't seen that shake out yet, but that's where I think this is headed. And I do think that's the companies that will emerge, those big ones, those, the ones that were unicorns a couple times over, are going to continue to start to make their way and test out those business models, ad services, whatever it's going to be, figure out how to get paid more along the lines of the traditional healthcare system, so they can, game the payments or whatever. But I think that that's where we're headed.
Well, Deven's already done that. Sorry, Deven, you were going to jump in around time.
Well, no, we sort of we've gone past the point, but the other thing that does occur to me, sort of along the lines of propping up incumbents, is we still do have a system where so much of these innovative companies are dependent on access to data and access to and relationships with healthcare institutions for which data is necessary. And we still, I don't think, have seen whether we have the right set of policies in place to facilitate the systems control of data to sort of be open to sharing it with innovators. Like we're continuing to sort of go down this path of certified systems and the need to connect into certified systems, with forgetting that these certified systems actually control the levers as to who gets in and who doesn't, and the price tag for connecting in that way. And that these are not public utilities, they are private companies. So we're investing a lot, and we have invested a lot, and we're continuing to invest a lot, both policy and financially, in a digital data system that it's under private company control.
Clearly, Jen's organization is going to fix that. Easy. All right. We'll try. All right, fantastic. So we're very close to the end here. So really quick, we're just going to do a quick go around and see what are people looking at, what have they got their eye on for the next couple of weeks, couple of months. Why don't I start with you, Raj?
Yeah, I'm going to go to what Deven was focusing on with Roe v. Wade. And obviously, we're all concerned about that. But if there can be, I don't know if I call it a silver lining, but an opportunity to think more about how data can be more liquid and more available, right, to the right people at the right time, then that could be something that we could be proud of.
All right, Jess.
I don't know. I really can't get past this Roe v. Wade thing. Like I'm so just shocked at that this is the state of women's health in our country. And it's just, I can't get past it.
No, it's going to occupy an enormous
No,
amount
I
of
really
space
can't,
for
because
us.
it has such far-reaching implications, as we've kind of talked through and touched on here. And it's just, I just can't understand what this does to women's rights, patients' rights, like that. Can't get past it.
Deven.
Yeah, I would like to hope that Raj is right, that this may be a silver lining for data interoperability initiatives as a way to sort of keep care available to people across state lines. I certainly hope so. It's an intriguing prospect. It's one that you certainly could see could get shut down, but it's also one where we've been working so hard. Federal policy has all been aligned toward opening that up. And hopefully that's, I think that gives me a bit of hope. So thank you, Raj. And excuse me for a minute, because someone's at my door.
Oh, let's see who it is. Special guest star.
Jen.
I mean, building all of this, it's mixed feelings, isn't it? In some cases I feel just like Jess, I want to kind of just throw my hands up and say, who freaking cares? Like, the whole thing is on fire. And on the other hand, we are responsible for finding those opportunities, those gaps. And like Deven, I hope that it's sort of what Raj envisages is what starts to transpire. And I think an important part of that is, what does it mean to be that telehealth care, right? For example, that can deliver. I think we need to move away from the fact that it's a visit that looks like this. I think we have to think more about that virtual first care, that, whether it's direct to consumer, whether it's a visit, that it's sort of full stack integration of a better way for caring with people. And hopefully we can forge ahead with the data environment that it's safer too, in every sense of the word, including around your information and your privacy, because in the digital era, that is a fundamental part of patient safety.
Well said indeed. You have been listening and watching to the THCB gang. I want to thank my guests. I'm Matthew Holt, THCB founder and publisher. We'll be back next week on May the 19th with an entirely new gang. But meanwhile, I want to thank my guests for this week. They were Jessica DaMassa from WTF Health. Used to be in Florida, now heading to Arizona or somewhere lost in the continental nomading across the US. Raj Aggarwal from Philadelphia. Deven McGraw was up in the Russian River, but now back in San Francisco. And Jennifer Goldsack, who's, I think, in the Tampa area of Florida, more or less. You've been listening to the either watching on the video or listening on the podcast to THCB Gang. Looking forward to seeing you all again. Thank you for watching and listening.